Dr. Manikanth Lodaya to all of you. He did his MBBS from Jawaharlal Nehru Medical College, Belgaum. That was in 1972 to 1978. Did his DA from Kasturba Medical College, Manipal, 1978 to 80. And MD Anesthesia from Karnataka Medical College, Hubli. That was from 1983 to 1985. And he was a faculty at Kasturba Medical College, Manipal from 1986 to 2001. And a faculty in SDM College of Medical Sciences, Dharwar from 2003 to 2007. And he was a faculty at Adi Chunchanagiri Institute of Medical Sciences from 2007 to 2011. So he was a consultant anesthetist and intensivist, Shri BDK, Lifeline Hospital, Hubli, 2007 till date. Now also he is working there only. So he has also done his fellowship in cardiac anesthesia from UK, 1995 to 1996. His main interests are regional anesthesia, obstetric anesthesia, and hobbies are ham radio, cycling, running, social contribution, mission smile. I was just interacting with him. He was telling me that his hobby of going on bicycling is so much. So recently, last year, he did bicycling from Bombay to Gujarat. It was 650 kilometers and 650 kilometers in 6 days. That is really great from Dr. Lodaya at this age. And me and we are of almost same age. So, but really, I appreciate his efforts in bicycling that long. That's how he is keeping himself very fit. So, over to you, sir, for your oration.
Thank you, Dr. Gurudat, for the nice introduction. And first of all, let me first thank the Department of Anesthesiology, KLE University, Belgaum, for giving me this opportunity for this prestigious oration. And also would like to thank the organizers and the scientific committee of the state conference for giving me this opportunity. My voice is a bit changed because I have not been well for the last 1 week. I had developed a respiratory tract infection. So please bear with me. I may be coughing in between and may be having a sips of water in between. So please bear with me. And my first introduction into anesthetic practice began at JNMC Belgaum when I was doing my internship. Very interestingly, when there was an internship, there was an optional posting of radiology, skin, anesthesia, and so many other subjects. And I opted to take anesthesia not because I was very much interested, but because half the time the operation theater used to be closed. So we could have a day off. And then our chief of anesthesia, Dr. Bellad, who's still very much alive and healthy, used to tell me to go to the minor OT, which you has to have in the evening, to give anesthesia for close reductions, abscess drainage, sebaceous cyst excisions, and things like that. And then we used to have open drop method. And I used to pour ether first and ethyl chloride later. And then the ward boy used to tell me that, no, first this and then this. That is how my anesthesia career started. And I miserably failed to get a single spinal in my 15 days of anesthesia posting. That was how miserable I was. So thanks to them that I've come into this field. And I developed a keen interest in regional anesthesia and obstetric. So I thought, let me tell you the experiences of my anesthesia. And since I can tap here, isn't it? Yeah. So my talk today would be limb blocks from blind probing to precision. Now, if I can ask you, how many of you practice regional anesthesia? If you can put your hands up. regional anesthesia, which includes spinal and epidural. How many of you practice limb blocks? That's a significant amount. Okay, we'll come to this question later in the talk. So, and I think many of people like me in this audience would have gone through all these techniques. Now, what I'd like to talk to you today is about what is the success of regional anesthesia. A few points about how do you evaluate these patients, how do you prepare, and how you take a consent of a patient whom you plan to give a limb block. A few points about local anesthetic and adjuvants. And I will talk about detail about the use of a peripheral nerve stimulator and a bit about ultrasound guided, because the modern day we are going more into ultrasound guided blocks, especially in the bigger institutions. And one of the forgotten topics when you give a peripheral nerve block is the complications of nerve blocks. And then I will summarize a few points in the end. Now, there are 3 points which lead to the success of regional anesthesia. Identifying the correct nerve or plexus. Getting the needle as close to the nerve as possible, that is the second. And then injecting your local anesthetic close to the plexus. Now, before the introduction of ultrasound, we had 2 techniques, paresthesia and a peripheral nerve stimulator. Now, the paresthesia principle mainly relied on producing a sensory sensation, and the patient would say that I'm getting so-and-so sensation. So that was because the needle would touch a nerve. Either it used to be the needle tip, or it could be the shaft of the needle as well. And this was short-lived. But this was a subjective sensation. You had to read the mind of the patient as what exactly he's saying. Whether he's saying as a feeling, or was he feeling it as a pain, or as a shooting sensation. So it was very, very subjective. So we didn't know whether it was actually a paresthesia or not. And the second thing, nerve stimulator. Nerve stimulator, you could get a motor response. So you knew that the needle tip is very close to the nerve. But the thing was, the needle doesn't block the nerve. It is a local anesthetic. So the local anesthetic could go any way, not necessarily towards the nerve. So these were the problems with these 2 things. So the success depends on, finally, the local anesthetic surrounding the nerve or the plexus, which gives you the success of the block. Now, coming to preoperative evaluation. Now, many times, especially you give nerve blocks, mainly in orthopedic surgery. Many of these patients come as an emergency, as polytrauma. And so, one thing we need to evaluate, apart from the general evaluation, I mean, you do an evaluation as a general, as though you're giving a general anesthetic. That is understood. But especially if you're giving a nerve block, you must look out for nerve injuries. These patients could have patients with fractured humerus, shaft humerus, patients with fractured clavicle who also have leg injuries, and so many other things. So you must look out for nerve injuries before you give the block. Injury to any other part of the body, because what happens in a polytrauma, you have a fracture of the humerus on the, say, left side of the body, and you have multiple rib fracture on the right side of the body. So positioning these patients become problem, and it may be very difficult for you to give the, even if you give the block, putting the patient in a lateral position is going to have severe pain. And he may have, or the surgery may involve both the upper limbs and the lower limbs. So you'll have to take all these factors into consideration before finally giving a block.
anxious to be awake and aware of the surgery. I've seen many, especially the Indian patients, they say, just put me to sleep. Just put me to sleep. I don't want to see the surgery. I'm afraid. So you'll have to take those factors into considerations. And when the patient's drape goes over the patient's face, the patient says, I can't breathe, open that, you have to lift the drape. The surgeon becomes irritated because you keep your hand moving under the drape. So these all factors you'll have to take into consideration. The position on the table. Many times the patient is on an orthopedic table with the limb sort of stretched out like that. So it'll be very difficult for you to give a block. And of course, remember, the state of the airway is very, very important. Difficult airway and regional anesthesia is a different subject altogether. I will not be discussing for the want of time. So the airway is the most crucial part. You must make sure that you'll be able to intubate the airway, at least put a laryngeal mask. And you must have access to the head as quickly as possible. So this is a very important. Preparation, of course, the duration of surgery, which will determine what type of block you will give, what is the type of local anesthetic you will inject, the position of the patient during surgery, as I've already said, and need for a bone graft. Many times what happens, the preoperatively you see the patient, you plan for a block, the patient is shifted into the operation table, then the surgeon at the last moment says, I will also need a bone graft. And then all your plans go hairy-wairy. Okay? So you make sure whether the patient, because if you're giving an upper limb block and the patient needs a bone graft, then what do? You give a local infiltration, or you again give a general anesthesia. So you have to take these factors into consideration. Now, as far as informed consent, this is why I'm picking this topic is because not many people will talk about consent while trying to give a block. Because many people, and including surgeons, you're just giving a block. What's the problem with that? You know? So, informed consent, one thing is you must take consent for general anesthesia as well, because the duration of surgery may be much prolonged, much longer than the duration of the block. Your block may be unsuccessful and you may require to give general anesthesia. So you will have to take a consent also for general anesthesia. And for when giving a nerve block, what are usually we tell the patient? We tell the patient, we'll give an injection here, this limb will be paralyzed, for 4 hours you will be all right. That is the usual thing. But there are a lot of problems involved. At the most, what do we tell them? That you'll have some pain here, discomfort here, and things like that. But we never tell them what is the serious injuries like nerve injury, a paralysis of a limb, and patients can have a cardiac arrest while giving a local anesthetic. Now, what literature says is that why do people do not tell about these details while giving a nerve block? We know everything about a spinal and epidural. We'll tell them you'll get a headache, you'll have backache, and things like that. But when giving a limb block, we never give details of what is the risk. One of the things they found out that the regional anesthetist, the person who specializes this, exactly doesn't know the incidence of, what is the incidence of nerve injury. What does the literature say? They do not know what is the incidence of nerve injury while giving a brachial plexus block. And so they do not comment on that. They do not inform the patient that this could happen. So one must always tell the risk of nerve injury, especially, particular patients who are on the information technology, who use a lot of computers, use a lot of the hands, things like that. You must really explain to them what can happen following a nerve block, so that they can make a right decision whether they want a regional technique or a general technique. Now, as far as local anesthesia is concerned, in the present scenario in India, you have several local anesthetics available. ropivacaine, bupivacaine, lignocaine, levobupivacaine, and things like that. So depending on the duration of surgery, one can choose what type of local anesthetic. Second is cardiotoxicity. The relevance of bupivacaine in today's practice is being questioned, whether one should use or not with the availability of ropivacaine because of its cardiotoxicity. Then the incidence of severity post-op pain. Remember that lower limb fractures carry a higher risk or have very severe pain as compared to upper limb. So you can decide which type of local anesthetic you want to give. The bupivacaine, ropivacaine would be good enough, or you just want to use lignocaine with adrenaline. And in patients with daycare surgery, where the patients are to go home by evening or by night, whether you want to use a short acting so that they are mobile by the end of the day, or you want to use long acting. I'm not talking of neural catheters, intravenous intraneural catheters, where we can give post-op pain relief even at home. I'm basically talking of single injection blocks. So these factors you take into consideration while choosing a local anesthetic. Similarly, with volume of local anesthetic, with the introduction of ultrasound, you have very small volumes of local anesthetics were given, and people sort of proudly say that I give only 7 ml of local anesthetic for an axillary block or a 10 ml for an interscalene block. I do not know the logic behind this because there are several complications while trying to give very low volume of blocks. And with the PNS technique, usually you give a sort of a larger volume of block. Then, of course, as with spinal epidural, we have a lot of additives. We don't give anything without additives. We mix things very much. We're happy to mix things. And the commonest is adrenaline. Adrenaline has an advantage. One thing, it can rule out intravenous injection. So you know for sure that you're not intravenously. But the only thing about adrenaline is that we use a concentration of 1:200,000. That's 5 mics per ml. And that, if injected intraneurally, can be neurotoxic. So they suggest that you use a mixture of 1:400,000. That is 2.5 mics per ml. Don't use the usual concentration. Use a more dilute concentration. You can still find an increase in heart rate and blood pressure if you accidentally give it intravenously. But the neurotoxicity, in case you inject it, give the local anesthetic intraneurally, the toxicity of the nerve will be very less. Of course, steroids, dexamethasone, very commonly used, but there are a lot of studies which says that intravenous dexamethasone during the block and adding dexamethasone into the local anesthetic have the same effect. Clonidine and dexmetodine, very popular, but they have a lot of side effects, hypotension, syncope, drowsiness, and things like that. But they all show to prolong the amount of block, but whether they are really useful or not is very questionable. Mixing of local anesthetics, this is also very common, very popular among our anesthetists. What is the idea behind mixing of a local anesthetic? We want a quick onset of action, and we want a long duration of action. Now, we have not been able to manufacture such a drug. We have not been able to manufacture such a drug. So how just about mixing lignocaine with bupivacaine will produce such a drug? It will not. It will not. And there are several studies which show that it has no effect. It does not prolong the effect. And there's always a question of risk of drug error. So you say 50% of lignocaine with adrenaline and 50% of 0.5% bupivacaine will be the exact dose. It doesn't happen like that. It's not that simple arithmetic. So the idea of mixing local anesthetic is no longer there. And now you have drugs like ropivacaine, which have a good, not very rapid onset of action, but a good fast onset of action and a long duration of action. Now coming to the main part of the lecture is the techniques of nerve localization. Basically, paresthesia, use of peripheral nerve stimulator, and ultrasound guided. Now, we all started off with paresthesia, and it was a good technique in the hands of many people, good operators. It's still a very good technique. And it was first described by Winnie, who said that one could elicit sensory paresthesia during insertion of needle into the brachial sheath. You're the first one to describe it. But, you know, paresthesia is a subjective sensation. It all depends on how the patient interprets the sensation. He could say pain. Suddenly he will say pain. And then you ask him, where is the pain? And he will point out to the neck and not to the arm. So there were several things, they are very subjective. So you really do not know whether the needle tip is close to the nerve or not. So it is very subjective. It can produce nerve injury. Of course, this nerve injury, several studies have shown that paresthesias do not produce more nerve injuries as that produced by using a peripheral nerve stimulator or an ultrasound. Because what causes paresthesia is again debatable. It need not be just the needle touching the nerve. It can be just a pressure sensation. A pressure sensation can also produce paresthesia. That is what they explain. So, but with repeated needling of the nerve can definitely produce an increased incidence of nerve injury. Patient discomfort. When you explain to the patient that you will feel like a shock in the arm, he will already start getting tensed up. At least I would. I'll be waiting, I'll hold my hand tight. What is going to happen? So he'll already be tensed up. And that awareness, that anxiety, that some shooting pain is going to go to my arm, really doesn't work well. So then came with the advancement of peripheral nerve stimulator. The paresthesia technique waned off, and peripheral nerve stimulator became a very popular technique. And the basic principle of this was that current is elicited either at the tip of the needle when you're using an insulated needle, or from the shaft and the tip when you're using a non-insulated needle. And the closer you go to the nerve, the lesser current is required. That is the basic principle. But although this concept is very simple, the fundamental principles are very, very complex. And we'll see how this controversy erupts. Now, the advantage over paresthesia was you have a visual sight of a muscle contracting. And you can say, when a particular muscle contracts, that this particular nerve is stimulated. Whereas in paresthesia, it was subjective. It all depended on how the patient interpreted the sensation. Here you know which muscle is contracted and you know which nerve is stimulated. Patient is comfortable. A bit of sedation and they won't mind their hand moving involuntarily. Although some people do become anxious, but most of the time they are quite comfortable with a bit of sedation. And you know, because you have stimulated nerve, that your needle tip is very close to the nerve and you are able to inject the local anesthetic. Now, what is the current needed to stimulate a nerve before you start injecting the local anesthetic? That is the question. So this was the earliest study in 1969 where they did it in the obturator nerve. These are not basically patients coming for surgery, but basically patients who had chronic pain syndromes and they had sort of hip problems and other issues where they wanted to give an obturator nerve block. And they were the ones who first said that 0.5 milliamperes of current is required to stimulate a nerve before you start injecting. So what they did is, they used landmark technique 1. They put in the needle according to the landmark technique. Then they used fluoroscopy and saw where exactly the nerve is. And then when they made sure that the needle was in the right position, they stimulated the nerve. And if the nerve was stimulated at 0.5 MA, then they said that the needle tip is close to the nerve, and they injected. And what they found is, in most of the patients, in 8 patients, they found that 0.5 was the correct value of current necessary to stimulate a nerve. But is this criterion reliable? Okay? That a current of 0.5 milliamperes and less means that the needle tip is close to the nerve. So when I put in a needle and put on the nerve stimulator, and if I stimulate the nerve at 0.5, and if I get a response, do I mean that the needle is close to the nerve and I start injecting the local nerve? Is this criterion? So let us go on to a few studies and see whether this criterion is reliable. Now before you go on to set, I just show you the picture of a nerve. When we say, what I want to explain here is what is intraneuronal. Intraneuronal. When the needle tip pierces the epineurium and goes inside, it is called intraneural. When the needle tip is outside the epineurium, it is outside the nerve. This is the basic definition. There are other things, intraneural, extrafascicular, intrafascicular. We will not go into that. But I just want to make this distinction between extraneural and intraneural. Now the first study, intraneural injection during nerve stimulation guided sciatic nerve block at the popliteal fossa. Now what they did in this, they used ultrasound first, and they measured the size of the popliteal nerve, in the sciatic nerve at the popliteal fossa. Then a blind person used a peripheral nerve stimulator technique and used a current of 0.5 to stimulate the nerve and injected the local anesthetic. After they injected the local anesthetic, they repeated the ultrasound and compared the size of the sciatic nerve before injection and after injection. As you can see, post-injection, NA stands for nerve area. It increased of more than 15% in 76% of patients. Nerve swelling with fascicular separation was observed in 88% of patients. So what I'm saying is, till the needle tip entered inside the nerve, there was no response to nerve stimulation, even at 0.5. Only when the needle tip entered the nerve at 0.5 milliamperes was there response to nerve stimulation. So when you get a response to nerve stimulation at 0.5 A, the needle tip may actually be inside the nerve. Now, is it also true that if you fail to produce a response when the current value is more than 0.5 MA, the probing needle is far away from the plexus? Now, the initial study said that when you are at 0.5 MA, if you get a stimulus, muscle response, that means the needle is very close. What they say is, you require 3 milliamperes to stimulate a nerve at a distance of 1 centimeter, and 0.5 MA at a distance of 0.5 millimeters, that is half a centimeter. So is it true that when the current value is more than 0.5 MA, the probing needle is far away? Now what do studies say? In a similar study, intraneural injection with low current stimulation during popliteal sciatic nerve block. Now these were 25 patients where they used combined ultrasound and nerve stimulator. But the endpoint was whether the needle was inside the nerve or you got a nerve stimulation. Whichever was first, then they injected the local anesthetic. So endpoint was either a motor response at 0.2 or 0.5, or the needle being intraneural. Because here they used ultrasound along with peripheral nerve stimulator. They used both. And whichever was the first, if they entered the nerve first, they gave the local anesthetic. If they got the motor response first to the nerve stimulation, they injected the local anesthetic. The only other criterion was the injection pressure. The pressure at which you inject the local anesthetic was less than 15 pounds per square inch. That is very, very important. Now, what are the results? In 83% of patients, motor response was seen only when the needle was intraneural. The nerve response was when the needle was inside the nerve in 83%. But the other surprising thing was, in the rest of the 16 patients, they did not get a motor response even at a current value of 1.5 mA. So what does this tell you? I said the basic, principle of nerve stimulation is easy, but its fundamental principles are quite complex. The only good thing about this is intraneural injections usually do not produce nerve injury. Okay? So it is rather complex. So you get confused. What do you do? What do you do? This demonstrates that the magnitude of current is no indication of how far or how close the needle tip is to the nerve. Now, what are the explanations for this? One is hyperpolarization. Now, as you introduce the needle and turn on the peripheral nerve stimulator, you go on stimulating the nerve. And at a particular point, when you're close to the nerve becomes hyperpolarized. That is, its threshold becomes quite high, or the negative potential decreases further, and you require higher current to stimulate the nerve. That is hyperpolarization. But when you're coming closer to the nerve, what do you do to your peripheral nerve stimulator? You reduce the current because you're coming close to the nerve. So then you reduce the current, the nerve is hyperpolarized, you will not be able to stimulate the nerve. That is one of the explanations. Second is the path of current flow. Now, in an equipment, you pass a current, you know exactly where it will go, what will happen, you have capacitors, resistors. But in tissue, it is totally different. Each tissue has different resistances, has different capacitors. The current you give from a peripheral nerve stimulator may not go towards the nerve at all. It may go, everything takes the path of least resistance. Even humans, for that matter. You always take a path of least resistance. So the current may go along a path of least resistance and may not go towards the nerve at all. So this is another explanation of why, even at a current of 1.5 milliamperes, you may not be able to stimulate the nerve. Now, there's another interesting study which studied the resistance, electrical resistance while stimulating the nerve. Okay? What was the resistance outside the nerve and what was the resistance inside the nerve? And this was studied in pigs. 8 pigs, 4 exposed, 4 non-exposed. 4 exposed the sciatic nerve, and they placed the probing needle at 1 centimeter apart at different locations. And they placed it a couple of centimeters away from the sciatic nerve. They brought it closer, and then they put it onto the epineurium. Then they punctured the epineurium, and they checked the resistances. Similarly, on the unexposed sciatic nerves, they used ultrasound. And they did the similar thing. And they used, these nerve stimulators, NHS-12, can measure impedance. These are available in the market. This costs around 1.25 lakhs only. So if you see the diagram of the electrical impedance, extraneural as well as intraneural. The lower half are all extraneural, and the black square diagrams are the intraneural. You see how much the resistance or the impedance, you call it impedance, increases very much when you are extraneural and intra. But there are a lot of other factors that can change this. This has still not become very much standardized procedure. So we are not still able to use this particular technique to detect whether the needle is extraneural or intraneural. Similarly, when using ultrasound guidance, they did this, extraneural, intraneural, and there was a marked difference in the resistance or impedance. Now, with all this, is it logical to think that if one elicits paresthesia intentionally or unintentionally, a motor response to PNS at the same position should automatically follow? Now, intentionally, I think more or less most of us have given up. But unintentionally, it can happen while introducing a needle. You can produce anesthesia. I mean, if many of us would have experienced while inserting the needle, suddenly the patient complains of some tingling numbness in the limbs. That is unintentional paresthesia. Now, if you produce paresthesia and you hold the needle there and turn on your peripheral nerve stimulator and stimulate the nerve, would you get a motor response? Logically, yes. Because you're close to the nerve, you have produced paresthesia, what else do you want? It should produce. So what do studies say? Inability to consistently elicit, inability to elicit a motor response from sensory paresthesia. Okay? Motor response in only 30% of patients. They elicited paresthesia intentionally and then used the nerve stimulator to stimulate the nerve. But they did not produce a motor response. There was no response. But they injected the local anesthetic and all had successful upper limb anesthesia, although there was no motor response. Similarly, in axillary block, only thing here, the incidence of successful motor block was much higher. 77% of patients were able to produce a motor response following a paresthesia response. Okay? 23% of patients produce a motor response between 0.5 and 5 mA. They required higher current to produce a response. Now, this all says that each area of the body has different tissue resistances. What is there in the neck is different from the axilla, is different from the femoral area. They all have different tissue resistances, different tissue impedance. So ideally, the current value will change from area to area. It should not be something a fixed 0.5 milliamperes is the gold standard. It cannot be like that because each tissue is different. The amount of fat, the amount of fibrous tissue, the type of nerve. If you go high up in the interscalene area, you will find a pure nerve. You will find only fascicles. You will not find fibrous tissue. But where you go to peripheral nerve, you will find a lot of fibrous tissue. So the amount of current will actually vary from area to area. So that one must remember. Now, what is the other reasons for increasing current threshold? Edema over the area, bleeding. Use a supraclavicular block, you puncture the subclavian artery, you produce an hematoma. Then you require higher current to stimulate the nerve because the current gets dispersed within the hematoma, which will not stimulate the nerve. So whenever you produce an hematoma, not only what happens is the anatomy is distorted, the plexus is displaced, but also you require higher amount of current to stimulate the nerve. Patients with diabetes who have myelopathy, who have loss of myelin sheath, autoimmune neuropathy, and patients with chemotherapy. Now, chemotherapy patients, those who receive the drugs, they are all neurotoxic drugs. So chemotherapy patients who have received, even in the past, will require a higher amount of current to stimulate the nerve. Now, who should inject the local anesthetic? Remember that somebody is operating the nerve stimulator, the main anesthetist is giving the block. So many times what happens is you cannot leave the needle because the needle is always can get displaced, especially where the block is quite superficial. Most of the shaft of the needle is outside the skin. So if you leave it, it's likely to drop and get displaced. So you want somebody else to inject, the assistant. Whereas deep blocks, if you're giving a lumbar plexus block or a sciatic block, classical sciatic block, these are quite deep blocks and the needle remains in place. But as supraclavicular, interscalene, they're hardly 2.5 centimeters in depth. So if you leave the needle, this is always going to get displaced. So you want to keep the needle firmly placed and you want somebody else to inject the local anesthetic. Now, what is important here is, very important is, what is the pressure at which you're injecting? Now, the technician, I mean, some people may have the luxury of having another anesthetist also to inject the drugs who will have an idea of how much pressure he's injecting. But if he's a technician, he's just going to push the syringe at whatever pressure. That is very important. Now, that's something called as what is the opening pressure. Now, how do you define opening pressure? Opening pressure is defined as the pressure to be applied to the plunger of the syringe to overcome the resistance at the tip of the needle and make the flow start. That is the initial pressure you put is very, very important. So manually, you can't say, I am pushing the needle, okay, this is okay. There's no way you can really know that. Even from experience, you cannot know whether ideally your opening pressure should be less than 15 pounds per square inch. Any pressure about 15 pounds per square inch, you are going to cause nerve injury. So how do we do that? How do we know? So you have, this is a study which was done. Opening pressure consistently detects needle nerve contact during ultrasound guided. They intentionally brought the needle tip onto the nerve and tried to inject. Okay? Although they didn't, the pressure rises more than 15 pounds per square inch, you need to stop. So there are two equipment that are available. One is the nerve guard from Pajunk, and one is from Breborn, is a monitoring device. And the first one, the nerve guard Pajunk, which is available in India, costs about 1,050 plus 12% GST. And I think it is a single-use device, which will allow the injection to local anesthetic to flow only if the pressure is less than 15 pounds per square inch. If the pressure is more than 15 pounds per square inch, the local anesthetic will not flow. So this is available. This is one of the safety guards. And high pressures, you can always expect nerve injury. This is one of the most important parameter. High pressures, you expect nerve injury. Whereas Breborn, still not available in India. About 15 days back, I rang up the distributor and he said, nobody asks for it. I think one of the things I would like to say is associations should bring up this matter with companies. People in higher authority in the association should bring up these matters to get these things into India for the benefit of patients and the benefit of anesthetists who can practice good regional anesthesia. So, as you can see, as you start injecting, if the pressure rises, then the top knob slowly started rising. But the disadvantage of this is that you have to keep looking at that. You have to keep looking at the pressure is rising. Whereas in the Pajunk one, either there is flow or there is no flow. You don't have to worry. But in the other one, you have to keep looking whether the pressure is rising or not. So These are the two useful gadgets to make sure that the pressure at which you are injecting is less than 15 pounds per square inch. Now, what we have understood so far, the magnitude of current intensity is no indication of how far or close you are to the nerve. Failure to get a motor response to nerve stimulation is no indication that the needle is not intraneural. You can be intraneural and still not get a motor response to nerve stimulation. Motor response need not necessarily follow paresthesia. You elicit paresthesia, turn your peripheral nerve stimulator on, try to stimulate the nerve, you may not get a response. High opening injection pressures do indicate needle-nerve contact. So this is very, very important. Unless you have the pressure guard or the pressure monitor, manually it is very difficult to say whether the pressure is more than 15 pounds per square inch or less. So how do we deal with this situation? First thing, let the patient be awake or minimally sedated so that when you're injecting, if the patient complains of pain or some funny sensation in the arm, you can stop injecting. Do not introduce the needle beyond the recommended depth, especially in superficial blocks and dangerous blocks, interscalene, supraclavicular blocks. They are very, very superficial. Now, what happens when you're doing a peripheral nerve stimulator block is, your eyes are concentrated on the limb movement. The limb is moving, and you're probing the needle, and you're not getting a response, so your needle is introduced further and further and further, without realizing that the whole depth of a 5 centimeter needle has gone inside. So you must be very careful. So what can you do for that? Either you put a sort of a marker on the needle, or you hold the needle at that particular depth. So when you're holding it, your hand will touch the skin as soon as you reach the depth. So make sure that you do not, even if you do not get a response, you withdraw the needle and redirect it. That is why you need to relook at landmarks. Now, relook at landmarks is very important in the sense you put a drape all around. There is a small eye opening in the drape. Very small eye opening. After you have failed a couple of times, you lose orientation as where exactly the needle is going because everything is so much covered up. So, if you fail a couple of times, remove the drape, check your landmarks again, and then reinsert the needle. Be wary of high opening injection pressures and pain of injection. And use ultrasound, PNS, and pressure monitors. So use ultrasound if you have, use a peripheral nerve stimulator along with it, and use a pressure monitor. This is what is called as triple monitoring, which makes it very, very safe for the patient as well as from a medical legal point of view for the anesthetist as well. So triple monitoring is very, very important. Remember, nerve stimulators may vary in their current output and may not be delivering the current. So if you do not have standard peripheral nerve stimulators who have not sort of standardized their current output, it may be very difficult. You may be setting a value of 1 milliamperes and will be actually delivering 0.5. And there are several studies where they have tested all these peripheral nerve stimulators. And especially at lower currents, they do not deliver, especially at 0.5 and less, where actually you want them. They do not deliver what you have set. Now, a few points about interscalene block. Now, interscalene block with a nerve stimulator, a deltoid response is very important. Why I'm saying a deltoid response is, it comes from C5 and C6, which is the upper part of the brachial plexus. So once you get this response, you need not probe the needle further down to get a biceps response or a hand response. Because every time you try to probe a needle, you are increasing the incidence of nerve injury. So if you get deltoid response. And the brachial plexus is stacked one upon the other. And if you go in the right direction, you should get a deltoid response first, because you're going from C5, C6, C7, C8, T1. So the first response should be a deltoid. And once you get that, you need not again probe the needle further down. You can go ahead and inject your local anesthetic. Now, supraclavicular brachial plexus block, we call it the spinal of the upper limb. You can do most of the things of the upper limb. If you give a slightly higher supraclavicular block, you can even do humerus fractures, humerus surgery. But in view of the complication of pneumothorax, can this be justified? Now, one of the reasons, most of us would try to give a brachial plexus block if the patient has some coexisting disease. He has COPD, or he has a cardiomyopathy, or the patient is very, very obese. And in these patients, you want to avoid general anesthesia, so you want to give a block. And in these situations, if you again produce a pneumothorax, you're adding injury to insult. So do we go ahead and give a supraclavicular block in these patients is the question. Should we avoid it? Should we stop teaching this in view of the pneumothorax that can cause? Of course, we have ultrasound now, but even with ultrasound, one can easily produce a pneumothorax. It's not that easy. Ultrasound, it's very easy to see the nerve, but actually performing the act is not that easy. So the question remains, do you still want to use? There are other techniques. You can use the axillary technique, or you can use the interscalene, lower interscalene, and try to avoid the pleura and prevent a pneumothorax. Axillary block, we try to give multiple injections. Now remember, multiple injections increases again. Every time you touch the needle to the nerve, there's always a chance of nerve injury. Or should we give a single injection? Axillary block used to be very common for surgeons rather than for anesthetists. Surgeon used to give the axillary block and do the surgeries. So, but multiple injections gives a greater success, but always there's the greatest chance of nerve injury, because each nerve, the radial nerve, the musculocutaneous, median, every time you're touching, injecting. So every time the incidence of nerve injury increases. Single injection with large volume. You get one nerve stimulation, you give 40 ml of local anesthetic. Will that work? Not always. Now coming to lower limb blocks. Question comes back again. How many of us practice lower limb blocks? Yes. Lower limb blocks is the thing of very dedicated or very fanatic regional anesthetists. They go for it. Most people will give upper limb blocks, but not many will give lower limb blocks. Now I'll talk a few things about the main lumbar plexus, sciatic nerve, femoral nerve, and the popliteal nerve. Now as we got the answer right here, not very, very popular, lower limb blocks. Now what is the reason behind it? You can get away with a single short spinal, epidural. Quickly in 5-10 minutes, everything is done and dusted. Very sure, very effective, 100% success. Here, if you want to block completely the whole lower limb, you'll have to give 2 blocks, a sciatic nerve block and a lumbar plexus block. Third, the depth of the nerves. They're very quite deep, unlike the upper limb blocks, which are quite superficial. And because you are giving 2 blocks, a lumbar plexus and a sciatic nerve, the amount of local anesthetic is going to be huge. You have to be very, very careful. But there are several advantages. Prolonged pain relief. Now the duration of pain relief in lower limb is much, much more than in upper limb blocks. With the same amount of local anesthetic dose and the same type of local anesthetic, the duration is much, much longer, even up to 24 to 30 hours. I was frightened once when I gave a sciatic nerve block, and more than 30 hours later, he still had not moved his toes and had not given any additive at all. No clonidine, no dexamethasone, no dexamethasone. So the duration is very, very long. You must remember that. Otherwise, you are going to get very tensed, and the surgeon is going to be more and more tense. He will keep calling you, telling patient is not moving the limb, and you will become more tense. So the duration is very long. But the other advantage is you can mobilize the patient early, especially lower limbs. Upper limbs, they will move around. Lower limb fractures, mobilizing is the big issue. Early rehab, early discharge, and minimal use of opioids. Another important thing is do not interfere with the respiratory function. Now, when you give a spinal and epidural, most of the time, your abdominal muscles are paralyzed. So a patient with COPD will not be able to cough and expectorate during the time of surgery and during the time the anesthetic is in place. Whereas in a limb block, the abdominal muscles are not paralyzed. He can still cough and expectorate. That's very, very important. Where complete sympathectomy is undesirable in a patient with cardiomyopathy, in patient with fixed outputs, where you don't want the blood pressure to drop drastically, this works very well. Patients with minor coagulation abnormalities, you're in a dilemma what to do, whether you should give spinal or not. INR is so much, platelet is so much. You can go ahead and give a regional block. For perioperative pain relief in combination with GA. So you can combine general anesthetic with a regional for pain relief, because pain in the lower limbs is much, much more severe than in the upper limbs. Remember that. Patients with head injury, you do not want to tap the CSF. You can give a lower limb block. Now, apart from the common contraindications of any regional technique, like coagulation abnormalities, patient refusal, infection at the site of a block, and so on and so forth, another important thing is compartment syndrome. Okay? Fresh fractures of the tibia and fibula, and traumatic and extensive elective orthopedic surgery, because it can produce compartment syndrome. A patient will not have complaint of pain, and the limb will become ischemic. So must remember that. And if you want to give a block, you must always be in continuous communication with your orthopedic surgeon. Discuss the issues and then only give a block. Now, lumbar plexus block, the important thing to remember about lumbar plexus block is that it should be considered equal to a central neuroaxial block, as good as a spinal or an epidural, because the block is very close to the epidural space. So you must take precautions while giving a lumbar plexus block. The amount of blood pressure drop can be as significant as an epidural block, especially if you are using high pressures to inject. When you inject under high pressures, the epidural is going to go into the epidural space, and the lumbar plexus can spread bilaterally as well. So be very, very careful while giving a lumbar plexus block. Femoral block, very simple, very easy, quite superficial, very helpful, especially patients coming with fracture neck femur, fracture shaft femur, immediately pain relief will be there. Only probable contraindication would be if the patient has had a femoral graft there for peripheral vascular disease. So be wary of that. Otherwise, a very simple, and you can give the block within 5 to 10 minutes. And the patient has good relief. And even before the X-ray is taken, you give the block, the patient is comfortable, because the X-ray technician is just going to lift the legs like that. He is not bothered what the patient has, and is going to shove the plate underneath the patient's femur. So you give a block, the patient is comfortable, and patient is also happy. Sciatic nerve, one of the longest nerve, one of the largest nerve. Although a deep nerve, is very wide, so very difficult for you to miss it, and you can give it right from its origin, right to its division into the popliteal fossa. There's a double injection technique which is described for sciatic nerve, because sciatic nerve is basically two nerves joined together, the tibial nerve and the common peroneal nerve. So what you can do is, if you are using a peripheral nerve stimulator, you can stimulate both halves of it and can produce two different responses. The advantage is the quicker onset of action and a lesser amount of local anesthetic required. So you can practice this. You can use a double injection technique. Now coming to the last part is the ultrasound in limb blocks. Now ultrasound has probably made regional anesthesia and especially limb blocks very popular, and more anesthetists to take up and perform limb blocks. And many people are still using, all the peripheral nerve stimulator is still the most popular method. Now, apart from the big machines, you can have it on your mobile phone as well. I think these probes are available in the Indian market. I thought I knew somebody, but then I tried to contact him, but he's not available. But the linear probe was available, not the high resolution flat probe. So now the great advantages in ultrasound, you can visualize nerves, vessels, muscles, tendons. You can follow the path of the needle. You can see the needle coming close to the nerve. You need not know about landmarks. You do a peripheral nerve stimulator technique, you have to see where the scalenus anterior is, medius is, anything is. If you have ultrasound, you just put the probe in the supraclavicular fossa and you can see the nerve. So you don't have to remember landmarks except for your examination. You have a variety of probe positions. You can put the probe in any position and perform the block as long as you see there are no vascular structures or other nerval tissues in the line of the path. You can visualize the spread of local anesthetic, because I've said while using a peripheral nerve stimulator, the local anesthetic may go somewhere else because the needle tip is not very close to the nerve. Here you can actually see the local anesthetic spreading, and because you can see it so close to the nerve and the spreading, you can use very low amount of local anesthetic. And complications you can avoid: pneumothorax, intraneural injections, intravenous injections, and so on. Now what are the advantages? A good success rate, high success rate, higher percentage of success compared to PNS. Now good operators of peripheral nerve stimulator will disagree with this. They can produce a good 90 to 95% of success using a peripheral nerve stimulators. They are very good at that. I know a couple of people who give a block using a peripheral nerve stimulator within a couple of minutes, and they are really good at it. So, you know, there are studies which say for and against. So good operators with peripheral nerve stimulator can really still produce good success rate. Time performed is less. Now we always think ultrasound machine, you get the machine, you prepare, you put the sterile probe over it, and you arrange the trolley and so on. It's going to take hell of a time. Forget it, I'll just use a peripheral nerve stimulator. But that is not so. Studies have shown it is actually less than when using a peripheral nerve stimulator. Because while using a peripheral nerve stimulator, you're using a blind procedure basically. So you're probing the needle, you don't get a stimulus, you're probing the needle again and again. Whereas with the ultrasound, you're seeing the nerve, you're seeing the plexus, you're using a needle, you're seeing the needle, and it is given one shot. So multiple punctures are avoided, multiple, accidental intravenous or intra-arterial injections are avoided, and so on and so forth. So don't go under the impression that an ultrasound will take a longer time to perform a block than a peripheral nerve stimulator. Not so. Speed of onset is definitely faster. Now, ultrasound in low-dose anesthetics, duration of action, as I've already told, much longer. And you can reduce the dose because You have to give a couple of blocks. And I said one of the disadvantages of using a lower limb block is because you are giving 2 blocks, the local anesthetic dosage you have to be very, very careful. If you're using ultrasound, you can use a lower dose. Now, ultrasound can prove the peripheral nerve stimulator wrong. Because your peripheral nerve stimulator, if the needle is still inside the nerve, you may not get a response. But if you're using ultrasound, you can see the nerve, you can see the needle very close to the nerve or inside the nerve. So, ultrasound has several advantages. You can actually see where the needle is, although you may not get a response to peripheral nerve stimulation. Now, we all said that we can see the needle, we can see the nerve, we can see the needle entering the nerve also, but does it prevent intraneural injection? We all afraid to inject the local anesthetic inside the nerve. That is the main purpose. We don't want to inject a local anesthetic, which is toxic. If you give it inside the nerve, a local anesthetic, because of its concentration going inside the nerve, is toxic to the nerve. If you give the local anesthetic outside the nerve, it is not toxic. So basically, you want to avoid an intraneural injection. But does ultrasound prevent it? Now, what does study say? Now, this is one study where the large amount of patients, 0.8%, you follow this patient, at 6 months he would have recovered, and 0.2% at the end of the year, the incidence becomes very much less. Okay? So, the incidence is very, very less. But one nerve injury you produce, one patient who keeps complaining, who gets into chronic pain, you had it. So, that is the greatest fear, although the incidence is extremely low. Now, the etiology can be anesthetic factors, patient factors, and surgical factors. Anesthetic factors can be the type of needle one uses. I'm talking of an insulated needle. So, needles have long bevels, short bevels, and needles with long bevels cause more injury than shorter bevels. The local anesthetic. Now, the dictum in limb blocks is you will use the lowest concentration of local anesthetic and use the lowest volume that is necessary, because the local anesthetic, if introduced intraneurally, is neurotoxic. So, don't try to give a 0.75% ropivacaine if only 0.5% is required. You don't really require 0.75%. 0.5% will do the job very easily. So, use the lowest concentration available. So, even if you inject it intraneurally, the toxic effect will be very less. Adrenaline. Adrenaline, you should be careful, especially in areas where the nerve is poorly vascularized, especially the sciatic nerve, and use a lower concentration of adrenaline. And intravascular. Never inject the drug intravascular. Patient factors, patients with diabetes mellitus, patients who have received chemotherapy, and patients who have got pre-existent neuropathy. Surgical factors, direct trauma while surgical handling, retraction, positioning, pressure dressings when they put a tight pressure bandage, and of course, tourniquet pressures. Very, very important. Now, what are the strategies to reduce nerve injury? Awake patient, minimal sedation. So, if the patient complains of pain or an unusual sensation, you can stop injecting the drug. Use ultrasound guidance, you have the facility. Echogenic needles. Echogenic needles are available and make use of them. I know of several expert ultrasound guide anesthesiologists who proudly say that I use an ordinary needle. But I don't think that would be fair for the patient, because they do it day in and day out. They use an ordinary needle ultrasound guidance. Use a tangential approach to the nerve. Don't hit the nerve directly. Go above it or below it. You need to go close to the nerve. You really don't have to enter the nerve. If you go close to the nerve, the local anesthetic will automatically spread. Avoidance of intraneural injections is sometimes difficult because even with ultrasound, it may be very difficult for you to differentiate the epineurum from the fibrous tissue. As I showed you in several studies, many injections were still made intraneural. But as long as they are not further inside the nerve, the incidence of nerve injury is extremely, extremely low. Triple monitoring, ultrasound, peripheral nerve stimulator, and pressure monitoring, if you have the facilities for all. Low local anesthetic concentration, very, very low, and reduced concentration of adrenaline. 1 in 400,000, okay? Make a dilute concentration. Of course, you may ask me now, how do I make? Because the vial comes in 1 in 200,000. Yes, you have to make it. 5 mics per ml to make it 2.5 mics per ml. Now, checklist for performing a nerve block, correct patient, correct site. Correct site is very, very important. Remember that, especially limb blocks, you know. Many orthopedic patients come to the OT with plaster of Paris, so you know that that is the site to be blocked. But lower limb blocks, you're putting the patient in hip surgery, putting in a lateral position. Sometimes, you know, that the orientation of the table changes, so be careful which side block. That is not an issue even if you give it on the wrong side, as long as the patient does not suffer any neural injury. Only if he suffers neural injury on the wrong side, then you're in trouble. Allergy and anticoagulation you have to check, especially drugs. Now you have, most elderly patients are on anticoagulants. And there are so many anticoagulants and there are so many manufacturers of these oral anticoagulants. You really need to check the name of the drug and check whether it is an anticoagulant. I've seen so many people who come to the table with an oral anticoagulant and then the surgery had to be postponed. So make sure that the patient is not on any anticoagulant. Okay, surgical procedure, consent, block plan combined, site marked, equipment available. This is like any other thing. You make preparations as you would make for a general anesthetic technique. Now, coming to the last and summarizing, what we need to go is go green. We need to go green. In the modern day, reduce our, what they call it, the carbon footprint. You know, we produce every day. So we need to go green. Try to use more and more of regional anesthetic techniques. Use less of volatile anesthetic agents. Use, especially volatile anesthetic agents, a small amount of that is metabolized in the body. Most of it goes into the air, entraps heat, and the life of anesthetic agent is nearly 120 years in the atmosphere. And for so long, the energy is trapped within these volatile anesthetic agents. So try to reduce your volatile anesthetic agents. Nitrous oxide, the largest producer of carbon dioxide in the atmosphere. Try to avoid using carbon dioxide. Of course, some people may say, shall go with total intravenous anesthesia. But there, you're using a lot of plastic and material that is again causing a lot of carbon footprint. So try to go regional as far as possible. And of course, you're inhaling so much of anesthetic gas. I know most institutions may have scavenging systems in place. Many times they don't work as well. So you try to avoid general anesthetic as far as possible. Summarizing, if the only benefit that regional anesthesia could offer were pain control, only pain control, it would be in itself a powerful reason to justify its use because of its great impact on patient satisfaction and potential benefit on rehab. Thank you very much.